Deborah Altschuler also be speaking? Or
just briefly.
Okay. And we'll open with you and then Fred after that.
Right.
Debbie Altschuler is the president of the National Pediculosis Association, and they have received an enormous number of calls in the last several years from people who feel that they are being parasitized by arthropods, that they're having a skin problem that is traceable to the presence of insects or mites or some other thing. The common thread is an enormous element of focus on this problem to the point of obsessiveness. Her normal duties in the National Pediculosis Association, of course, is lice and mainly head lice. Fred Frye is a distinguished lizard pathologist. He has his work is comparative pathology, and has been seeing a fair number of people who also are in this mode of having obsessive problems that are focused on self-diagnosed arthropods. He's at Davis, and I think he's got an appointment at UC Davis. In any event, that's the focus of the talk this afternoon. Are these patients who have these focus problems in this consultative practice, are they actually suffering from an insect or a mite infestation, or is it a figment of their imagination? Debbie then opens.
Okay. Thank you for having us. It's been quite challenging to be on the receiving end of these calls that have begun to come in at quite a rapid pace. It seems that most of the calls I'm taking now at the NPA are more related to this than they are to lice and scabies. Although initially the majority of the callers believe that they may have lice or they may have scabies, and that is predictably the first treatment that they receive. You may or may not be aware that the Merck manual directive when you look up scabies is if you can't get a definitive diagnosis, then do a therapeutic trial, unfortunately with lindane or with permethrin. And this has not been very productive in terms of this particular population. So what is one to do? There's an expression, for every good deed you will dearly pay, and I'm paying big time here, because there are now well over 150 reports from across the country where initially I was taking a full narrative on the phone to have the people explain in their own words what they were experiencing. And now it's just impossible. We don't have staff, we don't have time, and there still is a big problem with lice out there, so we have to keep our focus as well. So we're here today with Dr. Frye, who has pretty much rescued us at this juncture in terms of being able to document in just a couple of cases where we actually had specimens obtained by physicians and biopsies taken that were in fact reviewed by others. We've gotten them to Dr. Frye where he has seen evidence that they aren't necessarily negative, and although this may not provide all the answers, it certainly does give us some indication that there's a lot to be learned here. So to get on with Dr. Frye's presentation of his slides, I want to just show you a couple of slides of my own, because I have to, because I'm in the library here of tropical medicine, and because Dr. Zinzer's on the wall, and because I want to explain to you kind of what goes through my mind in trying to sort through this kind of information when, in fact, I personally I'm not a scientist, I'm not equipped to say yes or no, but I do feel a moral obligation to try and help get to the truth of the matter. So here is this is on my wall in my office. I found this while I was going through Dr. Zinzer's personal papers and feeling very guilty about it, thinking that if he were alive, there's no way I would ever have access to so many of his private matters. But when I came across this section of his Ether Day address, I felt like, well, maybe he would approve. And I think it's a good basis at the NPA for those of us who are sort of the gadflies in all of this. So we're not looking to prove anything. We're just trying to shed more light on it so that those who are in a position to do so can. And I think that the patients who are suffering expect that, no more, no less. And once that is obtained, then it's fair to make some sort of a determination. What we're finding at the NPA, however, is that people are going to shocking numbers of physicians who are either feeling totally inadequate in this or have such a bias against a person who describes themselves as being parasitized that they can't move quickly enough to get them out of their offices. So it's along these lines that we're trying to effect some change here. And of course, mainly from Dr. Zinzer also, we must keep our minds open and not toss out everything when in fact there may be some clue in this if we stay with it long enough. This is not a lost cause in the sense that it's one that can't be understood. It's a lost cause because there really isn't an orchestrated effort to try to get to the bottom of it. So we're hoping that maybe today will be a good start. And you can turn the lights back on. And with that, Dr. Frye, why don't you take over and show them your stuff? Yep.
Well, I'm appending this to my tie. Let me mention that I'm here with an open mind, and I would hope that some of you in this room can shed some light on what the heck is going on. It may very well be that when Deborah selected me, it was by serendipity, because I really have not published widely on medical entomology. I have a few papers on it, but nothing that distinguishes me personally. However, there was another Frye, suppose his name identical to mine, that was a co-author of a medical textbook on tropical medicine. And it may very well be entomology. It may be that's how my name came up. As I said before, my mind is open on this. Each of these patients was handled as if he or she was indeed involved with a true parasitism. And the cases I think that are most important are those that, let me turn the volume down on that, or if you can do without it, I can turn the mic off, whatever you wish. The ones that I think are most useful are those cases that actually have been handled by a physician, either by skin scraping or by the obtaining of full thickness skin biopsies and histologic sections. These are irrefutable. Most of the cases that we've had, and I've been personally involved, 15 or 16, and with accessions that amount now to well over 1,000 as far as individual specimens that I've looked at, quite a bit more than 1,000, and an enormous amount of time. And I think this is why the medical profession often has tended to drop this ball a little bit. It's difficult to get a false positive. It's very easy to get a false negative in diagnosing these individuals. There are a few things. Number one, we are surrounded by dust mites, and so it's possible to go ahead and introduce into a specimen a spurious pseudoparasite. Most of us are carrying Demodex follicularis in our nasal labial fold. Most of the people in this room probably are harboring this thing as a guest on our person, in our person. Scabies are fairly common. Scabies organisms are fairly common, and we can have a transfer of the canine scabies mite rather readily to humans. And as a matter of fact, I've seen some where we're not quite. Where there was some question as to whether the host gave it to the owner or the owner gave it to her canine host. I'm not using the gender her pejoratively. It happened to be a woman that was involved with her 2 dogs, and all 3 of them had the same mite. So with that, what I'd like to do is project a few slides for you. They are purposely in reverse order of the title of this presentation. So we're going to show you some of these that hopefully will be of interest to you. All right, now these are some of the things that we have found in these individuals. And by the way, these, with one exception, all of these were obtained by the patients themselves and submitted to me. I think the far better way would be to go ahead and have the physician himself or herself obtain these and submit them, because it's less likely that if there is any salting or seeding of the specimen, it's not going to occur with the physician obtaining the specimens themselves. But these are the type of things that we have found. Almost uniformly, we're finding fibers. And at first I read them out as, unfortunately, use the word silken. I no longer think that they have anything to do with silk, unless the person happens to be wearing silk clothing. Most of them are cotton. What I did is, and you'll see them later on, is taking specimens of regular cotton wool, of little lint balls taken from woven cotton fabric, and also from polar fill and Gore-Tex. And these were handled the same way that we would the specimens. They were mounted with Hoyers or Berlazes, cleared, and then photographed. The so-called fiber bugs that many of these people are reporting seeing, these are quite small, but some of them are large enough where they could be seen with a hand lens. And I think if you were picking these things off your own carcass, you might be tempted to believe they're bugs too. In some of them, you'll find human hairs that are mixed with them. Here's one here with a bit of a split end on one bit. Some of them are tightly woven, as if done by a machine or by some other agency. I don't think that this was done by an invertebrate. A chopped off piece of human hair here. In some cases, these are bundles of fibers or hairs or whatever that have been rather sharply truncated. In some cases, I've actually picked these apart, teased them apart under the scope, under the dissecting scope. And interestingly enough, in the first case that I did this, we actually found mites within the substance of one of these. It was negative until I did that, but that was the only case where that has actually happened. And I'll show that case in a bit. Other cases have yielded plant material. Sometimes pollen grains, sometimes these flat. And these, by the way, I don't know what it is, but it seems to be fairly ubiquitous. I found them on the West Coast. We found them in Arizona, Iowa, Oklahoma, and on the East Coast. Pardon me?
It looks like it's arthropod.
Arthropod?
Internal.
They are, but Andy, when they're fresh, before they're cleared, they're green. There are chloroplasts in this stuff. So I'm pretty convinced that it is plant. The cell structure, they have cell walls, which are not common to the animal kingdom. I'm pretty persuaded that it indeed is of plant origin. You can still see some chloroplasts here in these, and you see this vascular structure within there. A lot of plant, tiny plant seeds and plant fibers. I would submit that if a person had these in their underwear, they're pretty uncomfortable. And many of these came from people's perineal area. It's not going to be much fun having these sharp points, things like these, in your clothing.
That reminds me very much of CETA, a larval domesticator. It's almost
This one? Oh, yeah. This one? Could very well be. That's why we're here. You know, if you think that this is of dermestid or other similar origin, that's useful to know. These came from, by the way, one patient who we did identify mites from, both in skin biopsy as well as subsurface epidermis. Yeah, and by the way, most of the insects and arachnids that we have found have come from that one individual. This is one that has puzzled me. Anybody suggest what it might be? That's after about 72 hours of clearing under Berlazes.
I have seen it over and over again when people send things to the office and I just look under up on it. It's totally bizarre.
No, whether it's a plant origin, a pollen, a very tiny seed, whether it's of animal origin with all these things, appendages coming out, I don't know what it is. I can't get it to clear any more than that, even with heat. We've tried to clear it, and it's now been probably 2 months. I looked at it the other day, and it looks just like you can see it here. Anyone? Andy? Phil? Nope.
A woman who has said that her children come home and come through with head lice, and 2 days later, she has these bugs.
Now, I think that with all these hooklets on here, it would certainly stick to epidermal surface, to hair, to clothing, and it may very well be this is a very innocent thing that some plant is using to propagate its seeds or its pollen.
What size is that?
This is probably under about 240 magnification. A little bigger than that. You could probably see this with the naked eye as just a little dot. Okay, these are regular cotton fibers from a cotton ball. And you see the irregular diameter. Some of them are somewhat flattened. There's no particular structure to them. In comparison to a human hair, this is what they look like. This is from cotton lint from clothing. And fiberfill. Now, as far as the colors, I have seen yellow ones, green, red, and blue. They would tend to bleach out with Hoyers after a day or two. This is just an identification that's on the image itself, taken through the camera. Okay, as far as the animate objects, we're seeing Siphonopteran larvae, flea larvae, a variety of insects, winged insects particularly, some very tiny coleopterans, a lot of wing covers, elytra.
These are often patients?
You bet.
Collected by patients?
Collected by patients, combed from their hair, shaken from their clothes, combed from their pubic hair, taken from the perineum. A lot of these guys, we have seen Colembla. Here's one here. There's a better one that, I'm sorry, it'll be coming up in a bit. A variety of both dipteran and hymenopteran insects. Ants. No, no.
If you were to say take the scraping from a lesion,
you wouldn't find this.
Scrape the sole of the foot.
Yeah, you would not find these from the lesions you would be scraping. Absolutely not. These are things taken from the people's, mostly the hair. In this particular case, it's an elderly RN with an MPH. She uses a walker. She cannot lie in a bed, so in the evening she sits in a chair with ice packs on her head underneath the light, and I'm sure that many of these things have attracted to the light and are landing on her head. And so the next morning she feels these things crawling around her head. She combs them out. She has now shaved her head to avoid this kind of thing.
On the other hand, the hairs and the other scales and things that come off of these arthropods that are in the environment may serve as a source of allergy.
Exactly, absolutely. And you're going to get urticarial hairs, as a matter of fact, from spiders and other arthropods. But by the same token, I don't think it necessarily negates the fact that these people may have other parasites, or they may not. In some cases, the same individuals who will yield things like this ant will also have mites. And we have found mites on them. And in them, not just on them. So, and in other cases, people have just about torn their houses down because their houses were infested with something that they believed was infesting them. And so we find both egg and pupal cases of insects. That these people bring them in, they think that they are actually organisms, and they're not. Or if they're organisms, they are organisms that aren't necessarily pathogenic to humans. Collembolans, yes, we have seen them. And there was a thought that these things were causing the signs and symptoms in these individual patients. And yet we're dealing with an animal that ordinarily was thought to be not a parasite. There is a small body of literature, particularly in the Indian literature. There is some here in peer-reviewed literature in the United States that has described these as causing pruritus and actually parasitizing human beings. But they're extremely rare. So if you hear of hoofbeats, here's a case of a wildebeest rather than a horse. And this is one you haven't seen. This is from a patient we were talking about. And this apparently came from her nose, or came from the nasolabial fold between her cheek and her nose. I don't know what it is. It may very well be a collembolan. Anyone want to venture a guess on what we can turn the lights off and see if it will reveal a little bit more, but that's the best I can do with Hoyers or with the Berlazes. I don't see any spring, but the tergites are similar to what one would see in a collembolan. Now, I think the importance of a creature like this is not necessarily that it may have been combed from the hair, but rather this, where you have, we know that many of the arachnids have urticarial hairs and that they certainly can cause a great deal of local irritation. And with people experiencing the feeling of having something crawling on or in their skin, and then finding these things, that may very well be an explanation for some of the symptomatology. Okay. One thing that I would suggest as far as a protocol, and this maybe we have the wrong audience here, but this would more appropriately be addressed to dermatologists or family practitioners, would be if you're going to make a skin scraping, at least for goodness sakes, do it correctly. And I think that a proper skin scraping, if it's going to yield anything at all, it's going to have to be more than just very, very superficial. When I make them so that you get a very small amount of capillary bleeding. You're going down from the epidermis into fairly, certainly very close to the basement membrane. And if you do it, at least you have a better chance of finding something. Furthermore, rather than using oil, which will not yield a permanent mount, I go directly to Hoyers and then go ahead and cover slip it, and at least you can have a permanent record of what you have found. Also, rather than using the end of a slide, I prefer to use a number 15 barred blade and actually use that. It's a very fine blade. You can pick up very small amounts of material, transfer them to the slide with a drop or two of Hoyers, cover slip it, and I read it immediately, and then usually at 24-hour intervals until I'm satisfied there is nothing there. And I think you're less likely to come up with a false negative this way than you would the old traditional way of coming up with a very superficial little bit of an abrasion with using the slide. Also, this technique tends not to destroy the organism if they're there, whereas scraping with a slide, and then transferring it and further scraping it on with one slide onto another tends to break them up. One thing else that can be added to this would be to go ahead and using a brand new vacuum cleaner bag to vacuum the environment thoroughly, and then seal up the bag and send the sealed bag to somebody who's willing to look at it with a dissecting scope and then with a compound microscope. And I think that's a part of the protocol that should be added.
What could be done in the physicians examining them also? We have a similar situation with the rash of Lyme disease, erythema chronica migrans. And the recommendation is to obtain a color photograph with scale indicator so you can associate whatever comes from the lesion with an actual visual representation. But also, with respect to this, if you're obtaining a skin scraping from the lesion, you should also obtain a scraping from a control site on
Absolutely.
the body.
Absolutely. That's a good point. If you didn't hear it, I think that if you're doing a skin scraping from the lesion, there should be a reference control from some place that did not have a lesion. Furthermore, as a pathologist, when people send me specimens, I try to get a gradation from normal to abnormal so that I have a zone of transition that goes into a lesion. I've seen too many cases that were misdiagnosed because it wasn't a complete biopsy. Many fibrosarcomas, for instance, are misdiagnosed as fibromas because it's not a deep enough wedge to get a transition. And I think documentation is very important. The real problem that I think all of us are faced with is time. That a physician in his or her operatory, in the exam room, is not willing to take the time to do some of these properly. Furthermore, the entomologist, medical entomologist, the pathologist is not willing or able to devote the kind of time that I have taken or anybody else would take with the thorough evaluation of some of these. It's too easy to slough these people off as being delusional and just assume that they're delusional without actually giving them a fair examination. And that has been a real problem. I think most of you know what this stuff is, so I'm not going to belabor it. They're both very similar, and they're probably equivalent in the two. I prefer to use it a little bit thicker. In the Hoyers, they're using quite a bit of water. I think you can drop back a little bit and make it a little more viscid. Okay, these are the things that we actually have found. Remember, I was very concerned that we're not dealing with dust mites. And some things mitigate against that. The mouth parts of these animals certainly appear to be those of an obligate parasite. Some of them, as a matter of fact, have been found in epidermal tissue. In one case, it actually went below the epidermis. And then there's also the fact that, to a certain degree, these have yielded to ivermectin therapy. Andy, am I going too fast? So you want to take a little more time to look at these? Okay? Okay. Now, these are all from the same patient in several specimens. And these were taken from her body. Gravid female. Have you ever met her, by the way?
No.
These were taken prior to the most recent biopsies, which were taken on this side of her face over here. I met her in Arizona last month, and she went to a plastic and reconstructive surgeon. By this time, these are probably 2 or 3 years old, but she had some lesions up in here, and this guy was a wonderful set of hands. Removed not only the lesions, but also the scars, and left her essentially with a very excellent, a super cosmetic effect. I was very pleased with the job he did. Most of her biopsies look like this. It's essentially lichen simplex chronicus. There are a lot of thickening, parakeratosis, hyperkeratosis, a lot of burnishing. These people tend to work their skin over assiduously and continually. A lot of scurf. Her skin is lichenified. lot of inflammation, and it's usually mixed. Interesting enough, there are a fair number of lymphoplasmacytes in these patients. I think we can probably turn the lights off now. Again, you can see them a little better. A lot of perifollicular inflammation. In some cases, multinucleated giant cells and a lot of histiocytes. Makes you begin to wonder that maybe we're dealing with cutaneous leishmaniasis. And in this particular case, she was investigated for this and was found to be negative. She does not have leishmaniasis. But you can also get an idea that if you try to treat a lesion like this that is so well walled off with a fibrocollagens capsule, it's going to be pretty hard to drive almost any chemotherapeutic agent into the center of that lesion and get it to resolve. Okay, the elderly patient that we've had those mites, we found one in this area. And by the way, all these cases have been looked at by a dermatopathologists and have not only been read out as negative for invertebrates or arthropods, but usually are given a provisional diagnosis of delusional parasitosis, which on the face of it is unkind, and also from the standpoint of those of us who practice in California, it's probably unwise because we live in a very litigious society, more so in California perhaps than you have here. These people are understandably rather distressed when they get that diagnosis. At low power, we focus in on this little critter right here. Beg your pardon?
What distinguishes this from folliculitis?
Oh, I think it is folliculitis. And I think that folliculitis may or may not be associated with the presence of one or more of these mites in the epidermis, particularly if they're scratching it continually. For instance, in canines, staphylococcal dermatitis is very, very common, extremely common.
This would suggest an active sort of massaging in of the antigen as opposed to a process of penetration by an arthropod.
Well, as far as penetration, I have found them very, very close, right, actually contiguous with the sebaceous gland. So they're getting down fairly deep. Furthermore, they're defecating, so that we're getting fecal pellets that are present there too. As well as at the time of their death, they're going to probably set up more irritation as a dead mite than they would be as a living mite, even with the fecal pellets, because those are continually being shed and passed out through the opening of the pore. But I think very clearly on these you can see the serrated exoskeleton. And by the way, these are from a patient in which the pathologist read out as delusional parasitosis. And here, as a matter of fact, you can actually see the hypostome on this one. The only acaricide that I know of, other than, of course, they're using lindane to begin with. She doused herself with lindane. She has used, and she's treated herself. Her best physician, Dr. Quack, is, she's been using, she's been quacking merrily away on herself, buying veterinary drugs, and so she's been using ivermectin. And she's been using mega doses of ivermectin. You know, huge doses that are way beyond the manufacturer's recommendation of 200 micrograms per kilo. She started out at 800.
To her defense, however, she continues to go for these biopsies that are read as negative.
Yes.
And she continues to suffer from whatever it is she has. So for her to attempt to medicate herself is not unreasonable, although it's certainly not a good idea.
Well, she feels the medical profession has failed her.
Because I have a site down in Maryland where there's residual granulomatous type reactions to tick bites. From sensitization to tick bites, they get a lesion that lasts for weeks, if not months.
Oh, my wife has one. She's had about 15 years.
Disappear with retination.
Yeah, that's a good idea. My wife has one on her thigh from a tick bite, and she still has it, and she got it back in the 80s.
But I've heard that that's a decreasing number of complaints due to this residual tick bite reaction, simply probably because it just removes all of the skin, just exfoliates.
Yeah. Individual lesions can also, you can use cryotherapy, you can freeze them, they can be, excisional biopsy would resolve the problem too. Are we all in the room at least settled on the fact that this is Demodex? Phil? Anybody else?
It's logical,
Yeah. I think it's consistent with Demodex. That's what I'm faced with. And I think that Andy's characterization of these people as being highly focused is certainly fair. And it's not a pejorative. That indeed these people have really gone the route. We had one gentleman took his own life about a month ago because he felt that after seeing 47 physicians, losing his wife, his marriage, his livelihood, he had nothing else to lose but his life, and so he took that. I'm going to leave it open for discussion by those of you who are here, and by
or things that might be associated with allergic type reactions to
eosinophilia has been seen, and yes, and they've exceeded 20.
We have a couple of allergists in the room, but this doesn't seem like someone you would refer to for allergy testing. I mean, I'm sure a lot of us have Demodex invading our follicles, but none of us have the extent of the kind of lesions that these people have. One logical explanation might be sensitization, but on the other hand, these lesions don't seem to look as if it's a sensitization phenomenon.
No, we're not looking at an Arthur's reaction or anything like that. This is something that is it's a chronic granulomatous reaction is what we're getting with it.
Well, that's allergic type.
The interesting thing among the reports to the FDA are the consistencies among the way they perceive their infestations. That's what they have. You know, they feel like they're getting stuck by pins. They all show up with these fiber balls or whatever. Some people call after having suffered for years. Others call immediately when they first believe that something's gone amok, otherwise having perfectly normal lives, no medical problems. A lot of association with pets, living in homes that are very damp, having had water in the house. This particular woman that he has the slides for has been to an allergist. She's been to just about everyone, and is pretty desperate. That's another concern when you're on the receiving end of the calls, is how to manage these calls, how to advocate for them to have proper medical intervention that doesn't encourage them where they shouldn't be encouraged, but gives them a fair shake. They deserve that.
Some of them have had cats. It's quite obvious when I do their examine their material. I find feline hair. I don't think the cat has anything to do with it. That's my feeling. Although there certainly are plenty of mites that infest cats, but they're pretty host specific.
Rich, did you pass on that little thing from about Schaumer's disease?
No, I've got it on my desk.
Yeah, there are apparently straw mites, which, when in close contact with straw, will directly invade the skin and cause urticaria.
But those are, for the most part, nymphal. They're not the adult mite. You get lots of trabeculid mites will do that. And none of these, by the way, are consistent with trabeculid mites. They don't look like them.
The one other interesting observation that I have is that from a workup perspective, when a patient presents, these patients are expected to do things that you wouldn't expect them to do in any other medical situation. Bring me in your specimens. Dig it out yourself. Do whatever it is that you can, even though we're trying to focus Dr. Frye on only those specimens that are obtained by physicians through proper channels, so that we don't have that question all the time about, well, where did they find them? But again, I'm coming back to the intervention. Where in the system can we have a protocol that people can follow? If you can't do it, then find these people someone who can.
We have had a situation of going forward one step and going back one step. And a good example is it was this woman who you saw her face, who has actually dug material out of her skin, and then you find things that look like colembula. And the colembula by convention, is not thought to be a typical parasite.
If this is the same patient that I've dealt with on a number of occasions, it's not. We've seen a number of specimens of Columella submitted by patients, in one case removed with the help of the patient in a physician's office, but the physician apparently didn't really have a part in this, except supplying a jar of formalin. My feeling is that in several of these cases, the patients have seeded the samples. We have seen Columella, but separate from the skin sample in the formalin, and no indication within the skin that there was no sign of pathology, there was no tunnel or other lesion associated with it. Some of these patients we've seen things as surprising as Pediculosis. Obviously, either an accidental introduction into the vial or intentional.
We had one patient that I didn't show the slides because, frankly, I don't want to open myself up to a program. But she has sent in Lepidopteran larvae. Not something one would think to be feeding on the human host.
We had one sample 2 months ago of a leg of a grasshopper, supposedly removed from a lesion.
This is the kind of thing we're faced with. We're dealing with people who are absolutely desperate for some help. And had I known that it was going to be this time-consuming on my part, I probably would have backed off. I don't know I would have.
Once you've satisfied that there are no parasites there, what do you do with the patient?
I can't. I don't practice medicine.
Yeah, it's never, one is never able to say that there are no possible etiologic agents in a patient like this. What's needed is a hypothesis, some sort of a reasonable, testable hypothesis. We're probably dealing with a situation that has multiple etiologies. The common thread here is the obsessive nature of the patients. And there may be many things that are operating that make them that way. If we could only identify one or a limited number of testable hypotheses to try to tease out of this mass of very difficult patients some etiologic agents, that would be, I think, the way to move ahead.
That's what I've been trying. The thing is, you put your finger on it, maybe it's a bad pun, but the common fiber, maybe those little common fiber bugs, the so-called fiber bugs, are these wound, little lint, matted fibers. As I said, I've teased all of them apart. I only found one that had mice. Now, what is producing it? Are they a natural phenomenon, or are they being produced by either human hands or by the limbs of an arthropod? I don't know.
There is something as far as patient management that can be done. Several of our patients have seen a dermatologist that we work with, and he has treated these patients. If it appears that we cannot find a parasite in there, he then treats them with an anti-infective disorder drug, and it seems to cure the problem within a day or 2 days. Patients come back and say, "This is fantastic. I have no itching."
Do they know what the drug is?
In some cases they do, in some cases they don't. And I've asked him as far as liability, how can you do this, and he has no problem.
What does he treat them with?
I'll have to find out the name of the drug that he's using. It's an anti-infective disorder drug for obsessive compulsive behavior.
Right.
And again, within 24 hours he reports a cure.
By the way, one of the patients, I won't identify which one it was, has been on Prozac.
Mm-hmm. And so that's not
going back to your suggestion, which is well taken, we've just received word that in a town called Little America, Wyoming, the health department is inundated with these same kinds of calls. And I tried to reach the health officer there, who basically said, send me everything you have, and didn't take my call. But supposedly she's in touch with Roger Nashi at CDC in Fort Collins. But she concurs that there's something very unsettling about this. These people are calling her saying that they've purchased infested clothing and they're getting bitten. But it all, again, sounds very much like the calls that we're getting.
In some of those cases, it may be explained by fiberglass fiber or some other fiber that is causing irritation, where the patient has changed the detergent that he or she uses in washing their clothes, and there's a contact dermatitis associated with it.
We had one case of a woman who said that it could be picked up from brassieres, from clothing close to the skin surface, and it was attacking women's breasts. Yeah, the living bra. Latex, the living bra. I think we have more questions than we have answers.
Well, there are certain arthropods that are possibly worth phrasing a hypothesis around. The most obvious one is the follicle mite that we normally think of as being totally non-pathogenic in human hosts. But over the years there have been many implications of lesions that these things may be causing in people. And indeed related organisms, if not the same organism, I don't know, cause intense inflammatory reactions in various animals. Cattle, for example, there are major follicle mite problems.
But they're host specific, aren't they, in cattle?
I think so.
I think they are.
But maybe it's not. Maybe it's worth looking at. Maybe it's a human.
The one in bats is highly host specific. The one in dogs is specific. Monkeys have them.
You wouldn't anticipate, though, that a prevalent pathogen like this would be a source of inflammation.
Unless it's self-induced by constantly scratching the skin and making it worse because of bacterial infection of the follicle. Now that's possible too, and eventually you get a vicious circle going, where with scratching you get irritation, with irritation you get inflammation, with inflammation you get more scratching, and these things spread. Or
by the use of ivermectin. A dead a parasite is likely to excite an inflammatory reaction more frequently than a living one.
People do describe horrendous pain at certain intervals with this, and they call it a raging burning.
But some of those people have had that without ivermectin. I mean, ivermectin is a fairly late comer to this, really in the last 2 or 3 or 4 months. Prior to that time, they were. Yes.
From what just the individuals who've reported to us that they've used it, I mean, we don't really know about the whole. It's not a question that we ask really, but some people do offer the fact that they've been getting ivermectin from their veterinary supplier. Well, this one woman in particular with the lesions on her face.
And it's highly effective in domestic animals. Now, from the standpoint of scabies, which I think is another subset of these patients, they describe having tunnels that are vesicular, that are roofed, and they respond to ivermectin, as one would expect they would.
Well, if one were thinking in terms of a follicle mite etiology here, one might establish a protocol that would look for evidence of follicle mites in these patients and evidence that the follicle mites are doing something strange that they don't normally do. Perhaps that's the way to do it. If there were enough patients, if they were manageable enough, if that's
But, but how many of these do you find something like follicular mites or any organism other than compared to those where you don't find?
Well, the only ones I found follicular mites in are those people who have yielded to having a skin biopsy. Skin scrapings will, I have only seen those that have yielded sarcoptes. And as a matter of fact, the physician who diagnosed that patient as being delusional, faced with sending him photomicrographs of the mites, then came back and said, well, they're not really sarcoptes mites if they are dust mites. I mean, this guy is not willing to accept the fact that he may have blown the diagnosis. Certainly from a veterinary pathologist.
Only virtually all of us have follicle mites in our skin right now.
Those of us in this room, probably most of us have it, if not all of us.
It would be also helpful to have some consistency among the people who are looking at these things.
But this would not be the only disease where people have mental, you can call it delusional, but others. But you start with every single organ, whether it's the heart, the stomach, and everything. You have a huge number of patients who come with something that you never can find anything, and then whether it's myelin or some diet you do, and they may not. I think what you were discussing in terms of the compulsiveness about this may be even more so in terms of certainly the people who've written to me, the length of the letters, the pages of the stuff.
I've got them too.
Is more than usually people with, say, worried about an infection, malaria or something else. They're just amazing and then they come up with all these.
There's one other interesting thing that I wanted to tell you, Andy. The other people that we hear from who have the lindane poisoning, who call and say that since they use the lindane, they're having this and that. There are an interesting number of them who never mention that they think they have bugs now or that they're being parasitized. But what they describe sounds just like the people who do. I find these black specks. I feel this when I'm outside in the grass. I feel like I'm getting, stung by something that feels like a needle stick. I have lumps behind my neck or wherever. They never once say that I think I have bugs, but they sound very much like the people who think that they do. And I've not been able to go back. I haven't had a chance to go back and collect those people out again and try to maybe send them a questionnaire or whatever and revisit them and see if I can get more information from them. But that's always been in the back of my mind about this other group that sounds the same but doesn't come to us thinking that they have bugs. What do they have? And it's worth pursuing that. And also among the people, everyone is not obsessive that comes to the NPA. We get people very matter of fact that are still carrying on their livelihoods. A banker from Seoul, Korea, spent the night at a friend's house in Japan, came home, his wife is pregnant, he feels like he's getting bitten. What is this? She calls, she says, what do I use? Blah, blah, blah. And he sends between two stickies, 3M Post-its, his fiber bugs. He's not obsessed. He's just, wants some help. So we tend to focus ourselves on these people who are focused, but there are a good many of them who aren't. They just...
If there is one consistent finding in all of them, it's the fiber bug. A little wadded up piece of cotton or fabric, fiber lint.
I guess they're scratching and rubbing themselves.
I think we all have them on our bodies. We're wearing fabric, which we all are. We're going to transfer some of this detritus onto our skin. But it's certainly consistent. They do look like bugs under the scope. And some of them have gone to Toys R Us and bought a toy scope and looked at them and said, I see a bug.
Debbie's opening remarks indicated that this may be an emerging problem, that the frequency of this seems, in your experience at least, as though it were on the increase. Mm-hmm. Is that actually happening? Is that real, or is it an artifact of some...
Well, I first reported it to Fort Collins in April of last year, and then I made a trip down to Atlanta and I met with Thomas Navin, about this. They get one call a day of these. They don't know what they are, how to deal with them, so they don't deal with them. He thinks one call a day is a lot. And our association, like I said, we've been around for 14 years. We didn't ask for these. I know our number is out there quite a bit, but there appears to be something going on that we're getting maybe just a sense of. It's very strange.
Well, if the word is out that you're interested in it and we're listening.
Now the word is out. But initially, for quite a while, the word was not out. And actually, we have to reverse that word because it's overwhelming.
I think there is a suggestive nature here that people are talking to people. There's
Now they
networking
are.
going on, and so I'm convinced that it is because some of the calls that I've gotten and the letters I've received, people do indicate that they have spoken to someone else who called you or spoke to another patient who knew someone who knew someone.
Well, now
There's also a contagious aspect to this. This is what's most fascinating to me. I've had a number of calls with people whose neighbors, after riding in the car, also with the affected person, now report they have these little white thread-like things on the carpet of their car, on their clothing, and on their skin. They never noticed them before.
Well, I agree. I think there's we've created another monster in this. You're trading one problem for another. The fact that the word is out, these people who have their own network now, because the first thing we did was, I think, what we could do responsibly, we went to the government officials who were in place to help us with these things, and they really had a full plate, asking for help. So what does one do? This is another reason that we're here. So we connected these people to help each other while we were trying to find some assistance. I mean, Dr. Frye is the first one really who has...
There should be a page on the net where they could just...
They have a
On that bit.
They have a page.
Yeah.
Is there a page?
I'm sure there is a page.
Well, as a matter of
There's
fact,
like an
Andy,
internet group.
Bob Kimsey now has a network on the internet. He has a page, a newsletter.
On this problem.
Yes, but his is directed towards delusional parasitosis rather than really, is there a parasitism or is it all parasitosis? And I think the jury is still very much out, but I think it's now 11 to 12. The jury is coming up with a verdict. The thing I think that we would end with was, one, the fact that I think if there is a parasitism, then I think we're dealing with more than one organism. I think it's probably the flickner mite as well as scabies, and perhaps something else. Could be a sauropsid mite, I don't know. But certainly those two. And I think that we're also we need compassion for the people who have this condition. And if it is indeed mostly a psychiatric condition, then it should be addressed so that these people at least can have the problem resolved and get on with their lives.
But a punch biopsy is really very easy to do.
Oh, sure it is.
I think a skin, if it compared to saying someone is it's a psychiatric or not, that's nothing to do in an area.
Agreed.
If you suddenly find a mite there, you start wondering, even though it's not meant to be pathological, who knows?
I think what one would look at is not only the presence of the mite, but the presence of the host mounting an immune response to that. Because normally these mites are not very antigenic. And if you suddenly see an antigenic reaction with a lot of plasma cells around these, then I think it's meaningful. Then I think we have something.
A skin test.
Yes.
Also from the perspective of our association, where our mission is to protect people from the pesticides, to try to give them enough information so that they don't overzealously annihilate themselves. It's predictable that these people will use any and every conceivable way to undo this, especially if they don't have some sort of support. So we're always riding that fine line between encouraging them when they shouldn't be encouraged, but discouraging them from resorting to the things that they resort to. So
these people can be very demanding, as you well know. I've spent too many hours. Finally, I said, "Look, please don't call me. Filter me through. I can't get on with my life. I have to earn a living, and I can't do it if these people are going to tie up my phone and my fax."
A number, probably a half dozen of the dermatologists I've spoken to around the country by phone in the last year on this issue, probably 5 out of 6 have refused to take punch biopsies. If they don't feel it's warranted, they feel it would go against their creed to do no harm. They see no reason to take it, and they feel there's no lesion there that such a diagnosis is required for, such a procedure is required. So where do the patients turn? they're thrown out of 7 or 8 offices, or is it 47?
47 in one individual, yes.
Where do they go? Not here.
Well, the thing is if they don't have lesions, I can't argue with not taking a biopsy. If they have a lesion, if they have any bump, lump, red spot, whatever, if you can actually visualize this thing, then I think it's worthwhile taking a biopsy. I would argue only in not using a punch biopsy. I would much prefer a wedge biopsy. It yields a far better result because you can have a transition, a gradation from normal to abnormal. A punch biopsy is so small, the tree-fine punch, and I invented one, as a matter of fact. I'd much prefer, for this type of thing, a wedge.
I was thinking the 3 millimeter punch.
No, a 3 millimeter punch may not be big enough. Some of these things were about a centimeter in length. They're really quite large. And also, you can get a lot of sections on one slide, and you have. For instance, the physician who diagnosed this woman as delusional because he couldn't find any mites came back as an excuse to me, which all pathologists, I guess, use in our bag, is that, well, the microtome blade cut your sections and you have the mites. The ones that cut my sections, the mite wasn't there. I'm sorry, at 5 microns, I won't buy it. But that's the excuse, and it would stand up in court. Any excuse is better than none.
The hour is up, so we should thank Dr. Frye.
Thank you.
Thank you.
Boy, am I going to hear it when I get out of here.
No, you did fine.